Non, ça veut dire que tu passes
Est-ce que
en
vous
dernier.
pensez que je peux passer en premier ou pas?
Oui,
Ouais.
Ah, super. Parce qu'en fait, je promets pas d'être d'avoir une connexion parfaite tout le temps. Ouais.
Ça te dérange pas, Pierre-Hugues, si je passe en deux, parce que je suis à l'IRCAD.
je pense qu'on est online maintenant, les amis.
Ça veut dire que vous allez me laisser à la fin. C'est bien, merci les gars. J'apprécie.
Je serai là, Pierre-Hugues. Je serai là, Pierre-Hugues.
Super. Quand vous voulez, anytime.
Un de vous a par contre un bruit de fond.
Ok, vous me dites hein, quand j'y vais.
Voilà, c'est bon.
Je commence?
Non, non, 2 petites secondes.
Vous voyez mon écran ou pas?
Pas encore, mais je vais faire un petit mot d'introduction si vous permettez. So, dear colleagues, dear friends, it's my pleasure to welcome you for this new webinar organized by the ENS skill-based section. The topic of today is the devascularization and revascularization in case of skill-based tumors. We have 3 speakers. The first speaker is Dr. Marc-Antoine Laberry, working at Lariboisière Hospital in Paris, then followed by Sébastien Fröhlich, also that you know, working in the same hospital at Lariboisière Hospital. And finally, we have Pierre-Hugues Roche, working in Marseille. Those 3 speakers will share with us their experience on the topic. I just would like to make you one announcement. The skill-based section and my department will organize in Waterloo in September a very nice meeting between 7 and 9 September dedicated to skill-based pathologies, but many other topics in neurosurgery. So it's my pleasure to welcome you if you would like to attend this very interesting event in an historical location. You will be very much welcome. So I give now the floor to Dr. Marc-Antoine Laberry. Marc-Antoine, if you would like to show us your experience, mainly on the endovascular field, please.
Yes. Can you see my screen now?
Not yet.
Okay. So I just have to okay, is it okay now?
Screen is visible, but voila, perfect.
Okay. Hello, everyone. I'm Dr. Laberry. I'm interventional neuroradiologist at Lariboisière Hospital, and I have the chance to work with Sébastien Fröhlich's team. It's a pleasure and a great honor to present you our experience of pre-operative embolization of meningioma. So, what was our patient population at Lariboisière? Between 2015 and 2023, about 500 patients had preoperative DSA and or embolization of head tumor. Just adult population, as you can see. A third of them had only DSA without further embolization. As expected, meningioma and especially skull-based location were the most frequently treated tumor. You may notice that chordoma only DSA because they are not usually hypervascular tumors. Other tumors such nasopharyngeal fibroma, angiopericytoma, hemangioblastoma are much rarer in adults, and some others such as paraganglioma are more and more treated by radial surgery. All patients underwent DSA, of course, but including one or more 3D angiography. The real name is cone-beam artery phase CTA. And it's important to note that this vascular imaging technique have undergone considerable improvement with partial resolution over the last 5 years. Our protocol include a 10-second single spin rotation, 32 or 22 centimeters field of view, 2 cc second contrast injection, for 12 seconds with a 2-second delay. From this 3D image, which looks like a usual CTA, reconstruction with a small FOV and a strong kernel, it's radiological tricks, provides a wonderful artery resolution close to 100 micrometers. Here, if you look at this small quadrat here, you can see the M2 segment, M3 segment, M4 segment of the MCA. And if you focus just on this small rectangle, you can see this perforator of the white matter. So it's just amazing. I think it will become a very, very useful tool for neurosurgery in the next year. Thanks to this test, we were able to analyze feeders, of course, and in particular the dural feeders with great precision. We analyzed the most common feeders, which can be divided, as you know, in 6 groups from front to back. We will see later that these feeders are potentially accessible to embolization, all these feeders. So from front to back, you have the branches, dural branches arising from ophthalmic artery, ethmoidal, anterior, posterior ethmoidal arteries, recurrent and sphenoidal branches here. More laterally, you have feeders arising from internal maxillary artery, of course, the middle meningeal arteries, superficial temporal artery, and more medially, the ICF feeders, and especially the meningo-hypophyseal trunk and inferior lateral trunk. I just speak about the most common one. You know it very well, of course, these feeders. It's the one we usually occlude in embolization. You have also branches. All the branches of ascending pharyngeal artery can provide dural vascularization to meningioma, vertebral artery, basilar artery is more rare with trigeminal artery, and occipital artery also provide dural feeders. It should be noted that distinguishing meningioma according to their afferent branches is of a little interest, as dural afferent correspond perfectly to the location of the meningioma as seen on non-invasive imaging. But more interestingly is the DSA's ability to distinguish pial feeders, which are inconstant and unpredictable on non-invasive imaging, as in this patient who had a large temporal sphenoidal meningioma on MR, and this is a 3D DSA, and you can observe this is the ICA, the M1 segment of the MCA, and here a small pial feeders providing a quite large vascularization of the meningioma. Similarly, the existence of anastomosis between feeders could be very interesting to predict the efficacy of proximal occlusion of these feeders. Here in the meningioma, you have a large anastomosis between ECA, external carotid artery, and ICA branches, feeders of the meningioma. And if you just occlude one side, you won't have a devascularization, of course. So you have to analyze of these things. We also analyze intratumoral angioarchitecture, and it's quite, we have very few data about that, but it could be interesting in the future, you know, to distinguish microcirculation inside the meningioma. Here, a quite common pattern of high density radiant arteries. It's the most common pattern, and to distinguish it from other pattern like this one, which is more a low density diffuse artery. And it could be interesting to predict response to radiosurgery, to focus surgery to the hilum of this kind of artery. With a specific protocol, we can also analyze vein, but it's not the same 3D DSA. We have to adjust the protocol. It's not so useful actually, because MR angiography provides quite the same information. In this patient, you have a parietal vein, which is occluded close from the meningioma. This is a parasagittal meningioma. I think the veins are very interesting in parasagittal meningioma, less in skull-based meningioma. So it is occluded, and you can have the same information if you look very carefully on the MR, and you can also analyze the collateral suppleancy, which is very important, I think, to analyze before surgery. Balloon test occlusion is a very easy and safe tool when you have doubts about the circle of Willis supply. But it's not useful in each case. It's useful when, of course, the morphological analysis on non-invasive imaging show a hypoplasic segment, like here. You have a hypoplasic A1 segment, and the balloon test occlusion is very useful to predict the effect of a permanent or just a transient occlusion during surgery. We say that you need at least 1 millimeter large feeder circle of Willis supply for one cerebral artery or basilar artery territory. So what is our technique? What was our technique of embolization? Our aim was, of course, to occlude as many of feeders as possible with a close to zero risk. Why a close to zero risk? Because it's not the treatment is a second surgery, so you have to have a better safety and efficacy with two surgery rather than one. So it's a very important condition. And in this particular case, you have a blush before embolization. After embolization, you have normal blush. It's a complete embolization. It's wonderful, but we will see that it's not always this case. What was our tools or devices to occlude feeders? You have 4 different approaches. The first one, the simplest one, is using just coils. As you know, coils are platinum detachable or injectable devices like here. You need for that to be in a quite big artery, more than 0.7 millimeters. It's not so big, so you can occlude very small artery. Unfortunately, it provides only a proximal occlusion with no risk of collateral of reflow ischemia, because you can decide if you let the coils at the place you want. The only risk with coil is a failure, because you occlude proximally, so there is a risk of distal anastomosis. But it's a very safe way to occlude the feeders. The second way is particles, microparticles. It's a kind of plastic particles. It's polyvinyl alcohol. And we recommend this size of particles, 300 to 500 micrometers. Is important. We will see why, because smaller particles are probably responsible of hemorrhage, intratumoral hemorrhage after embolization. So the principle is very simple. You just inject particles in the flow. It's important to inject them in the flow. If the artery is occluded, it's not particles don't go distal, and there is a risk of reflux. And there is also a risk of pressure injection under pressure, which could be responsible of collateral ischemia by opening dangerous anastomosis. But if you just inject in the flow, that means you need a big artery for that, more than 1 millimeter. And if you take care about the risk of reflux and open dangerous anastomosis, for instance, you look that there are no ophthalmic artery arising from the ECA. In this condition, it provides a wonderful distal occlusion with a very low risk of collateral ischemia. Unfortunately, it's not relevant for pial embolization, ophthalmic artery, or feeders arising from ICA. Why? Because there is a too high risk of reflux in a very eloquent territory. The third approach is to occlude feeders with glue. It's a mixture of cyanoacrylate and iodinous oil. You can inject it in very, very small catheter, and it's just amazing because you can enter and occlude arteries as large as 0.5 millimeters. You can go everywhere with that. And if you take care about the risk of reflux and the risk of dangerous anastomosis, it's more tricky. This open and quiescent anastomosis, that means some territories are dangerous and other not. I will explain you later. If you respect these rules, it provides a proximal and distal occlusion, so it's wonderful. And but the risk of collateral ischemia is higher than microparticles and coils, because there is a risk of injection under pressure. It's not relevant for basal feeders of skin, and it's the big message is why it's not relevant, because can you hear me?
Yes, yes, very well.
Yes, okay. Basal feeders, as you know, there are lots of dangerous anastomosis. Even if you don't see them, if you inject under pressure, there is a risk of nerve palsy and embolization of eloquent territory. So the rule is never liquid agent, embolic agent in basal feeders. Ethylene vinyl alcohol, EVOH, it's onyx or squid, is rarely used was rarely used in all center. It's quite the same than glue, but it allows longer injection. Arteries need to be a little bit bigger. There is a risk of traction when you take back the microcatheter, which stick a little bit to the EVOH. It provides the same result as glue, same risk of collateral ischemia, and it's the same. It's not relevant for occlusion of basal feeder skin. So meningioma. So what were the best indication of embolization in our center? Of course, hypervascular tumors, especially extracranial and skull-based tumor. Why? Because in this tumor, feeders are easy to embolize. What does it mean, easy to embolize? Easy to embolize mean terminal feeders, no eloquent territory close from the location of the tumor. So long enough, big enough to navigate into the feeder, and not too tortuous for the navigation. So that's why extracranial skull base are the best indication. No distal anastomosis if you just do a proximal occlusion with coil. And I think the two other very important criteria are difficult surgical access, because it's very simple for the surgeon to occlude the feeders. It's no need to occlude it before, of course. And it's quite the same, but for very long procedure and big meningioma with risk of residual, I think to prepare the occlusion before, it's a gain of time and probably of outcome. What were the effects of this embolization? The objective effect are the effect that the neurosurgeon told us after embolization. Of course, it's known there is a risk, there is a reduction of the risk of bleeding. In some cases, the best cases, you have the dry tumor appearance. But also the reduction of the dissection time to access the feeders. Of course, if you occlude it, it's not needed to occlude it again. And another thing which is less known, but complete embolization like this, in this case, it's before embolization, and after embolization, you have a necrosis, makes the tumor softer and so more accessible to aspiration. Efficacy in literature, we can't assess the efficacy in our survey because it's not controlled. But in literature, efficacy of embolization is controversial. As you know, you just have data from meta-analysis of retrospective cohorts. What we know is that the result in some meta-analysis, it reduced the time of surgery and the rate of major complication. It increases the rate of resection. In some articles, it could improve functional outcome. It's, I think, very controversial. But I think the most important thing, and it's what I explained to the patient, if that it could reduce the risk of recurrence. It's not just a question of blood, of bleeding during the procedure, but if you can make the risk of recurrence lower in very big meningioma is a good challenge because it lower the risk of recurrence. Of course, there are complications, and we have to inform the patient about that. Different complications in our series, cerebral ischemia. Note that cerebral ischemia in our series is most often microembolism with small infarction like that, small dots in diffusion weight imaging, which are quite frequent and which are we recover completely in few days. So the prognosis of this kind of lesion is very good. We have this kind of lesion, and also when we embolize aneurysm, even with just diagnosis DSA, it's very frequent. Sometimes it's a larger infarction, and it could be responsible of a permanent disability. In our series is about 1% permanent disability. It's not a severe one. It's a ranking score 3, but it has been to be explained to the patient. There is a special information about navigation in ophthalmic artery, because the risk of retina ischemia is probably higher. Even a small clot and a small onboard in ophthalmic artery can be responsible of blindness, partial blindness. In our series, this risk was about 0.7% in a patient who had already a very severe visual impairment. Nerve palsy, nerve ischemia was never observed in our series, probably because we never use liquid embolic agent in basal feeders. Edema is a very frightening complication, and we prevent it by making embolization a short time before surgery. I think it's most frequent when you use squid or onyx like EVOH. And in this patient, INR frequently recommend systematic steroids after procedure. We never had malignant edema after surgery, even in patients that we have treated a few days before surgery. So I think it's not so frequent without EVOH. Intratumoral hemorrhage is probably the most severe and dangerous complication of embolization. The patient could die because there is a massive mass effect. In our series, we had absolutely no case of such intratumoral hemorrhage, probably because we use larger particles than 100 micron. It has been described in the literature just for smaller particles because particles migrate into veins, making high pressure into capillary. The treatment, the embolization had some limitation, of course, and the main limitation is that the total or subtotal devascularization is not the rule, and it's only observed in 20% of the meningioma. Why? Because we don't treat dangerous feeders, and our aim is just to have the close to zero risk, as I told you. So it depends, of course, of the feeders. For middle meningeal artery, the rate of embolization is quite 100% because it's very easy to navigate into it. Ascending pharyngeal artery is the same. It's more tricky for ICA feeders like MHT or ILT, especially ILT, because as you know, it's recurrent and sometimes there is stenosis at the origin of the artery. In this case, we just let the feeder patent. Of course, we don't take any risk. PIAL also can be embolized in quite a third of the case, so it could be interesting for neurosurgeon. We usually not embolize skin territory like temporal superficial temporal artery or occipital artery, because it's very easy for the neurosurgeon to occlude it before surgery, and there is a small risk of skin necrosis. The other limitation is that there is a secondary revascularization if there is no surgery. It's not very quick, very fast, but can you hear me now? Is it okay?
Yes, there is no interruption.
Yeah, sorry. When you, it takes months or sometimes year, but you will have after embolization always a revascularization. Here in this patient, who was contraindicated for surgery, we performed complete embolization of this meningioma with necrosis and shrinking of the tumor. You can see 3 months later, which was still visible quite 1 year later, but half and 1 year later, the meningioma was growing again. So just before conclusion, few illustrative cases. Here you have a patient with a large sphenoidal meningioma here on the 3D DSA. You can see very well these feeders, which is a recurrent branch meningeal artery arising from the ophthalmic artery. It's an actual reconstruction plane. And here is the pterional axis. So this is a large, long, and not too tortuous feeder, so it's easy for us to occlude it. But on the same way, on the other side, on the other hand, sorry, this is a feeder quite easy to occlude very quickly during surgery. So what you have to do, because it was very easy to embolize it and to get this softening of the tumor, we performed the embolization. So it was quite simple. We use intermediate catheter here. We put it at the origin of the ophthalmic artery, and with a small micro catheter, we enter these feeders to place one coils, one second coils, and we got the occlusion of the feeders. This second case is petroclival meningioma with, you can recognize here the MHT, the meningohypophyseal trunk, which is large, not too tortuous, so it's possible to occlude it. The pterional and posterior petrozotomy access makes the occlusion of these feeders not too difficult, but there is a little way before the occlusion of this feeder. So it could be interesting for the neurosurgeon, and it's what we decided with the neurosurgeon, of course. Here you have a 3D reconstruction of this feeder. We enter with the microcatheter and to deploy the coils. So, of course, because it's basal feeders, it's forbidden to use liquid embolic agent and microparticles, because there is a risk of reflux into the ICA. So it's just possible to put coils, but it's easy and very efficacious. There is a big efficacy of that. We just use a balloon to deploy the coils into the branch. And the third case is this very big petrous, cleavous, cavernous recurrence of meningioma. And the 3D DSA in this lateral view showed this, this meningeal artery feeders, and here it's petrous branch, providing a large vascularization of this meningioma. If you look carefully, there is the internal maxillary artery here, and here the artery crossing through the foramina rotundum. So it's the foramina rotundum artery. And more at the back, you probably recognize a branch of the ascending pharyngeal artery. You have exactly the same view, but in 2D DSA. Here, pharyngeal, middle meningeal, and rotunda foramina artery. It is basal feeders. It's not possible to occlude with liquid embolic agent. So what do we do? What did we do? So the first one, this is the ascending pharyngeal artery. This artery is quite small, so it's not possible to use particles. It's too small for that. We need to be in the flow. Forbidden to put liquid agent, embolic agent, so we just put a coil into this branch. It's very easy and very safe. This is the same view, the same artery, but in a coronal view. You can observe the wonderful resolution of this picture. This is the 2D DSA, where you recognize the shape of the APA artery, and after the 2 coil embolization. This very big middle meningeal artery is sufficiently large to put particles inside. So this is the same artery, but a coronal view here. We just put a catheter here and occlude with microparticles, 300, 500 microparticles, and finish with coils. This is the same artery. Just to a reminder to say that this is the middle meningeal artery, the spinosum foramina, and this part is not the squamous part for me, because here you have an the meningolacrimal anastomosis. Even if you don't see it, it could be open if you inject liquid embolic agent. So in the yellow part, no liquid embolic agent, and in the squamous segments, you can put liquid embolic agents. The last one was the foramina rotundum artery that we occlude. This is the coronal view. You can notice the wonderful resolution, and coronal, the axial view, the 2D view very quickly, and we put coils with complete occlusion of these 3 feeders. It's before embolization, and here you have the coils into the foramina of these feeders. The last patient is the one we have seen the case just in the beginning of this presentation, with the pial feeders here, which is a kind of anterior temporal artery arising from the MCA. Okay, this is a high resolution view of this artery. The feeders arise from the MCA here, and the feeders has a long way into the tumor without branches for the brain en passage. So it's a terminal artery. We can occlude it with glue or any liquid embolic agent very easily. This is the microcatheter into the small feeders, and here the glue injection. You can see the glue going distally to the vessel. We continue on the injection. We continue on, and here you can observe a small reflex. When you have this reflex, you just have to take back the microcatheter very quickly here, and the occlusion is performed very easily. In conclusion, pre-operative embolization of skull-based hypervascular tumor is very safe if you accept that complete devascularization is not the goal. Complete devascularization is rarely reached and likely not needed. As I told you, this treatment should be considered as one of the steps of the surgery, and therefore resulting in pre-treatment consultation with informed consent. It's not just DSA, and even the DSA could be performed ideally days before embolization to allow sufficient time with the neurosurgeon to discuss each feeder's occlusion, the benefit-risk ratio of each feeder's occlusion. It is particularly interesting, I think, in large tumor for which the operating time is long and there is a risk of residual. Its benefits in terms of prevention of recurrence and, of course, favorable outcome have yet to be demonstrated. Thank you for your attention.
Thank you so much, Dr. Laberry, for this very nice and complete overview of the endovascular perspective. We will shift now to the talk of Sébastien Folisch, who is working with you. So, Sébastien, you are now in IRCAD, but you take a few minutes to discuss with us the surgical perspective. So, please, Sébastien, Marc-Antoine, if you can stop to share your screen.
Yes. Just
you show us, Marc-Antoine, very interesting images with very high resolution based on 3D. So those images were truly impressive to show all the detail you can observe on the preoperative workup. Sébastien, are you integrating such information in your management?
Absolutely.
So show us.
I am extremely lucky to have Marc-Antoine working with us. It's that's exactly what I would like to talk about. So yes, Marc-Antoine, thank you for this presentation. It's really, really nice. And I have to say that I am fortunate to work with quite amazing endovascular team. Marc-Antoine is one of our endovascular neuroradiologists, and we work very closely. Whenever I have a complex cases, like some of the cases he showed, it's really, really helpful. And this is part of my talk. So Marc-Antoine showed some cases of petroclival meningioma. As you know, it's definitely one of the, I'm sorry. Let me go back. As you know, it's a very challenging tumor to treat, petroclival meningioma. It's a tumor with different classification. We know the Kawase classification. I will not remind the classification because one of the, I think, very interesting addition to this classification is to include the feeders. And this paper from Saito team is very nice because it emphasizes the fact that in order to build a strategy, surgical strategies, it's not a question only of epicenter of displacement on the nerve, but it's also a question of controlling the feeders. And this classification is based on that also, according to the epicenter, according to the displacement of the nerve, there is also specific feeders. And this is definitely something we use, but you can only use this if you have a 3D angio like the one that Marc-Antoine have shown. The vascularization of those petroclival meningioma is very complex. This is a very nice study from Antoine Hamel, a French anatomist, and he describes the branches of the meningohypophyseal trunk feeding petroclival. There is a lot of variations, and building your approach only on anatomical knowledge is not enough. It's different in each patient, and having a 3D angio is extremely helpful to understand this vascularization before. Why is it nice? For large or giant petroclival, I am not using the retrosig craniotomy. The retrosig, one of its disadvantages is that you reach the tumor base last. So it's not really an approach based on the control of the feeders, but combined petrosal, anterior petrosal approach, yes, they are based on control of the feeders because you want to reach the tumor base first. And for this, having the understanding of the feeders is nice because you can change, adjust the approach according to the feeders you want to target. Which are the feeders in petroclival? Middle meningeal artery with the anterior petrosal. It's quite easy to control because it's part of the approach. You have to cut the middle meningeal artery. Menengohypophyseal trunk, that's not so easy to control surgically, but with the resection of the tent, which is a technique that Fukushima introduced, you devascularize branches from this trunk. And then you may have feeders from the ascending pharyngeal artery. And for us as neurosurgeon, it's very difficult to control. And this is where I am extremely happy to have Marc-Antoine doing an angio, finding that there is feeders, and then putting some coils in the branches of the ascending pharyngeal for this meningioma. This is drawings from Kentaro Watanabe, who is in Japan now. You all know him. He's a great surgeon. He was my fellow in Lariboisière, and he did those drawings to illustrate the feeders of those petroclival branch from the meningohypophyseal trunk, branch from ascending pharyngeal artery, which usually anastomose together, the medial tentorial artery, which is usually one of the main feeders, because you know that the tumor base of those petroclival is very often also the tentorium. There is always, almost always, parts of the tentorium involved as the tumor base, and also the feeders from the tentorium, which is the tentorial artery. So yes, we according to the type of meningioma we are dealing with, we target, we change the approach. For the tentorial type of petroclival meningioma, which arise mainly from the lower surface of the tent, pushing 5 inferiorly, doing a tentorial resection is very important. Anterior cut, posterior cut, after you've done your combined petrosal. For petrous apex type, this is very nicely controlled with an anterior petrosal approach. Dorsal meningeal artery, lateral branch, you expose the dura of the posterior fossa, you coagulate this dura, and yes, you can have the surprise once you open the dura to have a very soft tumor, bloodless, quite easy to resect. Clivus type is the most difficult type of petroclival to resect because it's very medial. 5 is lateral, 7 and 8 is lateral. You have a small corridor if you go retro 6. This is why combined petrosal is nice. But here, it's a little bit sometimes more complex to get to the feeders because some of those feeders are more medial. But here also, getting to the clival dura and coagulating the clival dura can definitely be useful, but it's something you control usually quite late during the surgery. This is a series of large and giant petroclival meningioma we did from October 2012, October 2020. I will not go over the details of this series, just to say that I'm talking about big tumors. I'm talking about complex tumors with brainstem edema, with hydrocephalus. This is for those cases that I'm doing combined petrosal, not for mid-size or small ones. You see that very often we do 3D angio. I think Marc-Antoine will confirm that now we do it systematically. In this series, some of the early case, we were not doing it systematically. It gives you an overview of the feeders, middle meningeal, ascending pharyngeal branches from the ICA. You see it's 81% of the cases. Ascending pharyngeal is the branch when it gives some feeders. I really like Marc-Antoine to coil because this branch is tough to reach with my approach. And I had the surprise in few cases when it was the main feeders, you know, when it's a mid-clivus, inferior clivus, sometimes nothing comes from the carotid artery. And I had the surprise in few occasions to find a completely necrosed tumor that was sucked in less than 1 hour. the approach was much longer than the tumor resection because it was almost liquid, especially because we also wait overnight before doing the surgery. They are doing angio embolization the day before, and we do the resection the day after, which I guess give time also for the tumor to necrose. So anterior petrosal, you come from the front, you drill the petrous apex, expose posterior fossa dura, and you can target the feeders from middle meningeal artery, part of the approach, but also ICA branches. This is a nice drawing from Kentaro showing with this little cross the feeders that you can easily coagulate. Posterior and combined petrosal, it's not really an approach targeted to the bony base of the tumor, but the advantage is that you can easily resect the tentorium easily. I exaggerate a little bit. It's not necessarily easy to cut this tentorium that is usually infiltrated, usually very thick, sometimes calcified. But with this anterior cut, posterior cut, that you have access to with the combined petrosal, you can also first create a nice window that gives you multiple line of sight to the tumor, and secondly, you can significantly devascularize the tumor. And at the end of this tentorial resection, you usually have the nice surprise to have a tumor that is softer and with much less bleeding than what it would have been without this technical step. So what are the advantages for me of the angio and embolization? It's exactly what Marc-Antoine said. Understanding of the vascular anatomy, extremely important, because based on this, we built also our approach. Reduce blood loss, easier debulking because it's bleeding less, so you can use the CUSA longer without a need for coagulation inside the tumor. It's faster debulking because it may be much softer. And sometimes, yes, you expect a difficult cleavage plane with the brainstem on the pre-op MRI, but after embolization, because there is a strong difference in consistency between a very soft necrosed tumor on the brainstem, it can be easier. And you know that in case of brainstem edema, extremely dangerous to peel the tumor away from the brainstem. But if you can suck it because it's necrosed, then yes, it can be a significant advantage. Difficult to predict, but you can have the nice surprise to see that during surgery. Does it reduce risk of recurrence? I don't know. We need more time to be sure of that. This is a case I did recently of combined petrosal for this clival type of meningioma. I'm sorry, I could not bring the angio because I forgot to include it. I did a combined petrosal here, and it's typically a case, I go rapidly over the video. It's typically a case where this bony work, combined petrosal drilling, expose the tumor base first. And here in this case, I had the surprise, they embolize the ascending pharyngeal. I had the surprise, in fact, during the surgery to face a very soft tumor. I was not expecting it because it was a recurrent tumor after radiation. And usually those are not very nice. They are bloody tumor. They can be very fibrous. But here it was quite easy to resect. This is an endolymphatic sac. This is the anterior petrosectomy. We do quite targeted now combined petrosal, focusing on the petrous ridge. This is opening Meckel's cave. And this is here what I want to show you, the tentorial resection with the anterior cut, posterior cut, the tent is removed. And now I have a nice window to the tumor. And you see how easy I sucked this tumor. Still, it was difficult with the perforators, but I mean, definitely, first, embolization of the ascending pharyngeal helped me. And secondly, the approach with the devascularization of the tumor it provided definitely helped me to resect this tumor. Post-operative MRI was nice. And we achieved near complete resection of this tumor. This is a very interesting case for which I have to say I could not have resected this tumor without Marc-Antoine doing embolization before. This, I had no idea about the diagnosis, but someone in my team during the staff meeting say, why don't you think it could be a pitycytoma? I have to say I had no clue about pitycytoma before, but looking at the literature, we find out that pitycytoma is an extremely bloody tumor, and there is some series published with mortality rates, which is quite scary. So we did MRI and we decided to do an angio for this tumor, and it confirmed that it was like a sponge of blood, extremely vascularized lesion. We thought at the beginning, before knowing that it was a pitycytoma, of going endoscopic. I think if we would have gone endoscopic for a bloody tumor like this, probably the patient would not have made it, or at least it would have been extremely difficult. So here, Marc-Antoine did some embolization. If he's still online, he can confirm, of a tiny branch of the superior hypophyseal artery with some coil inside of it. I think it's a quite challenging embolization because it's not so easy to bring a catheter into it. But if you look at the postoperative angio, there is no more blood into this tumor. And yes, this was pre-op, this is post-op, completely bloodless during the surgery. The approach as used here was not endoscopic because I was afraid of other complications such as CSF leakage, and I would have need to cut the pituitary stalk, or at least to go through the pituitary gland to get to the tumor. I wanted to try to preserve the pituitary function. So we did here a posterior petrosal approach. It's not the purpose of this lecture to show you the technique, but I did purely posterior petrosal without anterior petrosectomy here. Extremely targeted approach to the petrous ridge. I just drilled the posterior semicircular canal and superior semicircular canal. You see that I am not looking for fascial nerve. And then I opened the dura. I deal also with some difficulties with the vein. This is also why the angio, 3D angio is nice, because combined with the MRI, you have a very nice understanding of the venous drainage of those tumors. And this is a tumor resection. I go rapidly on it. It was completely bloodless tumor, very limited blood inside of it. And the tumor was suckable. So I don't know what it's like when it's not embolized, because I have extremely limited experience with this pathology. But here, at least, it was soft. And I have the feeling it was soft also because of the embolization. Postoperative MRI, we kept the stalk. In an extremely bloody tumor, I don't think I would have been able to keep the stalk, but here I was able to keep the stalk because I could see something in this deep hole. This is another case of foramen magnum meningioma, lower clivus meningioma. Here, difficult case. I have two fears. First, the feeders. Location is very midline. If I use a far lateral approach, I will have to cross the lower cranial nerve. And this patient already have some issue with his tongue. And my second fear is the anterior spinal artery. So here, good indication to do 3D angio. And this is what our colleagues have done. You see here the MRI. It's really a midline tumor. It's more lower clivus type of meningioma than foramen magnum. Look at the feeders coming from the ascending pharyngeal here. This, I asked for embolization, and this is what they did. They could quite easily embolize these branches for the meningioma. If you look at the post-op embolization, this is coil into ascending pharyngeal, but there was also feeders from the ICA. And this is a confirmation that it's not a foramen magnum meningioma. It's a clival inferior clival, mid-clivus, clivus meningioma, because feeders come also from above. This, I think Marc-Antoine will confirm, it was difficult to embolize, so they didn't do it. But another advantage for me was to understand the feeders, but also the anterior medullary artery. You see it in the coronal section here. The anterior medullary artery here. This is what I was afraid of. You see that there is some anastomosis with the feeders, and this is the main danger of this surgery. I used endoscopic endonasal approach in this case. I show you rapidly the dissection. I left some tumor attached to the vertebral artery and also to the anterior medullary arteries that you can see here. In a patient like this, I left this piece on the junction between medullary artery and both vertebral artery. In a patient like this, you also have to be extremely careful post-op to have enough blood pressure to avoid vasospasm. And this is something I say to the anesthesiologist post-op, avoid hypotension post-operatively. One final case of cavernous sinus exenteration. We are doing some cases like this, mainly for recurrent meningioma after radiation therapy. So it's aggressive tumor. Patient is already ophthalmoplegic, usually because it's a growing tumor, rapidly growing tumor. This is a series that Bernard Georges published in 2004. Those indications must be thought very carefully because there is mortality, and in a significant number of cases, even if you do the exenteration, the tumor is coming back. So I have to say, I'm not doing this very often because the chance of success in terms of tumor control and avoiding complication is not very important. This was a case referred to me with a meningioma operated before, radiated with fractionated radiation therapy, and start to grow 3 years after. I did a cavernous sinus exenteration in this patient, but the strategies was complex, and I wanted first to make sure that I could sacrifice the carotid artery. So I don't know if it was you, Marc-Antoine, but balloon test occlusion was done, and you see that there was 0.5 delay at the venous phase. We do it with a patient awake. We lower the blood pressure of 20 points, I think for 20 minutes, and we do careful clinical exam of those patients. So it was considered as a balloon test occlusion that the patient passed successfully, but in fact, after the carotid artery was embolized with coil, occluded with coil, but we kept those patients flat for at least 1 week, and we progressively ask the patient to sit and then to stand up. We are very careful with those patients after the balloon test occlusion. It was the case in this patient, but when she started to sit, she developed hemiparesis on the right side with aphasia. We did an MRI, we saw this stroke, and she repeated stroke for a few days after the initial one. So we kept the patient flat, and because the patient was operated before, we were in a difficult situation because there was no more STA. So we did an occipital artery to MCA bypass. It's a challenging bypass because not so easy to dissect the occipital artery for such a long way, enough to go to distal branch, M4 branches of the MCA. This is pictures of the bypass I did. I skip the video, but it's a little bit painful to watch. Here is a bypass. It worked, and this is a post-operative CT scan. The bypass was open. We progressively elevated the patient, sitting first and walking then. On about 1 month after, or 1.5 months after, I did the cavernous sinus exenteration of this patient. It was a grade 2 meningioma, not a grade 3, with a high mitotic index, between 10 and 15 mitotic index. And this was 7 years ago. And the patient is still intact, no recurrence. It doesn't mean that she is cured, but it was quite successful. I have other patients like this where I did something similar and the patient recurred lower at the level of the dural tail of these tumors that I could not resect completely, also because I didn't saw that there was some infiltration away from the main epicenter of the tumor. So you have to be very careful when you do those, because in this case, we had to cut the cranial nerve. She was already ophthalmoplegic, but we had to cut 5, and she had no hypoesthesia before. So you bring significant morbidity to the patient, significant risk. In Bernard Georges series, there is 2 or 3 patients who died on 18 patients. So you need to make sure that you can at least give a significant chance of the patient to be cured. Otherwise, I think it's not worth taking this type of risk. Thank you very much for your attention.
Thank you so much, Sébastien. You show us again how you master such difficult tumors and the nice collaboration you have with your endovascular colleague. Is there any other indication during which you use to ask a pre-operative devascularization, any other kind of skull-based tumor, especially when you see the good result of your colleague?
Well, we do it for some big, convexity meningioma.
Yes, or sphenoidal or anterior.
Yes, sphenoidal. When we have a big tumor and we suspect a bloody tumor, quite easily we ask for an angio. And now we have such a collaboration that if they feel it's worth doing it, they just do it. But yes, we do quite easily an angio for the big meningioma cases. I ask also angio for chordoma patient, but there is no embolization. But sometimes I ask for looking at the size of the vertebral artery and also some feeders coming from the vertebral artery for the spinal cord.
Do you sometimes fuse the pre-operative 3D DSA in the neuronavigation system to directly target a feeder?
We start to do it, but you need to ask first to the neuroradiologist interventional to make a wide field for the 3D angio. Not only a quarter of the head, but the full head. And then you can put it in the machine for fusion. Marc-Antoine will confirm. And yes, it's helpful in some cases because you want really to target the feeders. We've done it recently. I don't remember for a few cases. And it was nice.
It's very valuable indeed. So thank you again, Sébastien. I know you are just extremely busy in IRCAD now and to take your time. So we move to your talk, Pierre-Hugues.
Yeah. Can you hear me? Yes.
You are with us? Yes. You perfectly.
So let me know how to proceed to share my screen, partager l'écran. This is right?
Until now, not yet, but.
You're gonna let me know if it works, right?
It works, but
okay.
I don't see the screen yet in full mode. No. With a Mac, it's sometimes troublesome. Okay, do we have the slideshow? Yes? Yes, but we have to try if the second one is appearing. Sometimes it's blocked on the first one, but just try. Okay, it works. Yes, perfect.
Okay, thank you guys. I'm happy to share this session with you. Unfortunately, most of us focused on devascularization and not in revascularization, but hopefully Sébastien showed a case which is very eloquent, and sometimes we need to We need to master microvascular surgical technique, because I do believe that being a nice neurosurgeon, skull-based neurosurgeon, means to be able to be a vascular neurosurgeon as well. I was pretty much convinced, but by what has been shown by the two lectures, even though I do not do exactly the same, particularly for meningioma. I must confess that we do not make any more angio before the surgery, and we do not embolize the meningioma anymore in our team, even though we did in the past, probably because we I mean, it's demanding, time consuming, and but I'm pretty much convinced that it works. The problem for me is the criterions for the selection of the patients who are eligible for that. Anyway, just starting with a regular case, this patient was 18 years old, a guy coming from Africa with a cranial deformity, and you can see both eyes. You can see that this patient came with nasal obstruction, and they did a biopsy there, and as expected, they experienced such a huge bleeding that they had difficulties to control. At the end, they sent the patient, and this is a typical feature of a juvenile nasopharyngeal angiofibroma. And JNA is probably one of the best indications for pre-op embolization. And all of us, we are convinced that embolizing the branch coming from the external carotid artery, which was the case on both sides, particularly the maxillary artery on both sides, and trying to be super selective for carotidian branches is mandatory to achieve proper resection of this patient. So it was done, and hopefully it helped for the surgery. So JNA is an indication for sure. So what the rationale to offer pre-amp embolization for skull-based tumors? First is to decrease the blood loss. All of us are convinced that embolizing properly this huge tumor with a vascular texture will help to reduce the blood loss. And it's also the case for meningiomas, particularly large petroclival meningioma. It's a long-lasting procedure. When you are operating during 6 years, the approach is bleeding, is bloody, the surgery is bloody, so it's probably helpful to embolize first these patients. I'm convinced that embolizing these tumors is helpful to modify the texture and to make it softer, of course. And probably it's helpful to optimize the plan of dissection. Sebastian told that if the tumor is softer, probably it will be better to control the interface between the brainstem and the tumor itself. Well, sometimes it works, sometimes it doesn't work. When you have the perforators involved, when you have the tumor which is interposed between the basilar artery and the ventral brainstem, it's probably still difficult to remove this part of the tumor. So facilitation of the resection is the goal of this embolization. Sometimes it works, sometimes it doesn't. We have two kinds of devascularization of the tumors. The first one is embolization before the surgery. And our radiologist did offer a very convincing lecture showing particularly super selective catheterization, and cone beam image is probably very helpful to analyze the microvascularization of the tumor. So pre-op embolization is something which works. Perioperative occlusion, perioperative devascularization is the key, and Sebastian emphasized the need to master the skull-based technique to control the feeders. And that's probably why I little bit gave up with the pre-op embolization of meningioma. Since we use this transpetrosal approach, you have an early control of the tumor. And of course, if you do manage properly the tentorium, you will control the Bernasconi artery and all the feeders coming from the cavernous sinus carotid artery. Nevertheless, it's helpful to embolize, and I'm convinced. So let's talk about the pre-op embolization. It has been told previously, so I won't go through the details because my knowledge is one of the literature, and my previous experience is pretty much from the past. There are techniques, there are indications, there are results. About the techniques, the previous speaker told about The device we use, of course, the coiling is something very important, but you have the proximal control of the artery with coiling. We have two kinds of embolic materials. We have the particles, including gel form, polyvinyl alcohol, and microsphere or ambersphere. The advantage of the particle is that you can control the caliber of the particle and offer a pre-tumorous embolization and avoid the complications of the cranial nerve pulses. You have liquid embolic agents like glue or like onyx, which have the advantage to provide an embolization directly at the level of the tumor itself, but with sometimes perhaps more complications. Of course, the technique improved with selective catheterism, the use of microcatheters, balloons to protect and to avoid reflux. Provocative tests. I don't know if the guys from Paris they do that, but the ability to do that awake and to administer lidocaine into the during the embolization to simulate some deficit or not is something which is helpful in the hands of the guys who are doing that. About the indications, we have three big players. We have the JNA. I showed you an example. You have the paraganglioma. Some of them are in the hands of the neurosurgeons and ENT, of course, but still we have to operate some paragangliomas, and of course, skull-based meningiomas, which is the most frequent, but I would say the most controversial about the indications. We did a publication years ago about our experience of large, extra large, giant JNA. And at that time, we operated this patient without any endoscopic technique. We operated the patient with transfascial approach, paralateral nasal, degloving, transmaxillary. And in this series of 15 giant paraganglioma, JNA, you can see that 13 of them were embolized before surgery. So I would say that embolization of JNAs is mandatory because of before the surgery. There is no question about that. And we did that, and thanks to this technique, we were able to achieve quite good resections. I show you a case of on the left. This patient was operated by a combined approach on the left. You see it was operated by a mid-fascial degloving plus modified preauricular infratemporal fossa technique, and the surgery was achieved in a very significant way. But of course, the embolization, you can see the coils in the internal maxillary artery. Of course, pre-op embolization was mandatory. On the right side, you see another case, which is a complex case because you have a transcranial involvement of the tumor here. Of course, all this DNA, they comes from the pterygoid plate, and they involve all the sinus, the infratemporal fossa, and sometimes they move up to the intracranial compartment. And this patient was embolized first, no way for that. He was operated with two approaches, a transcranial and a paralateral nasal, and we left some piece of tumor at the level of the cavernous sinus, and this part of tumor was eligible for gamma, and he was treated with gamma, and at the end, the control was excellent in the long term. We had two complications with embolization. One was an immediate permanent hemiparesis due to migration of the embolic agent into the internal carotid artery. And another one was the cutaneous necrosis in a small part of the skin, which was not very serious. Another big player is paraganglioma. We do have, and I'm sure Sebastian do have the same. We do have sometimes this giant paraganglioma. You have both compartments which involve which are involved by the disease. You have the intracranial compartment of the disease, CPA, jugular foramen, but you have also the infratemporal fossa. This patient was a 60-year-old woman coming from another country. Hopefully, the lower cranial nerves were already disabled, and in these cases, we selected the radiologist selected the onyx to embolize this patient. He delivered. You can see the cast here, and he delivered a fantastic amount of onyx in this case. And he told me that he confessed that the total expense with onyx was 30,000 euros in this case. So this is something that is never addressed in the series, but embolization is time consuming, and sometimes it's expensive too. And we have to consider that, of course, it's worthy in this kind of very complex case, but it's expense that should be underlined. And definitely such kind of embolization was very helpful in this case to remove the tumor. We probably left some piece of tumor at the level of the internal carotid artery in the petrous bone. We did a giant petrosectomy, but by the way, the petrosectomy was almost done by the tumor by itself. But it was helpful. It modified the texture. The tumor was softer. Still, it was bleeding because they did not achieve a complete occlusion of the feeders, but was very efficient and was very helpful for the surgery. So this giant paraganglioma, you know, they are eligible for pre-op embolization, and I'm very much convinced that it works. We do have complication. You see here series from the publication of paraganglioma which has been treated with embolization before surgery. Regardless the agent which has been administered, whatever was onyx of polyvinyl alcohol, you do have some complication, particularly cranial nerves deficits, because of probably occlusion of the vasa nervorum of the tumor, of the vasa nervorum, which occlude the vascularization of the nerve. And if I move back to the case I showed you previously, since the nerves were already in severe deficit, the risk on the nerves was zero. That's why we put it onyx directly into the tumor. So there are complications, and regardless the agent you offer, and this is a message. The problem is to assess in the series of the literature the percentage of deficit. It's pretty much difficult because the device are improving, and to have the results of previous device it's already too late because new device comes, and so it's almost difficult to know about the deficits, probably around 5% in the Honest series. Okay, about the skull-based meningioma, this is a question I would like to address to Sebastian and our radiologist. How to predict the vascularity of these meningiomas? Of course, if you don't do angio, systematic angio before the surgery, it's very difficult to predict the vascularity. And there are publications, particularly this one in GNS in 2018, measuring the flow voids with the T2 weighted image. It's a kind of volumetric analysis. It's with a special soft, and they measure what they call the MVI. And it's interesting to observe that the MVI they showed in the pre-op MRI is strongly correlated to the blood loss they obtained during the surgery. So probably this non-invasive way to measure the vascularization of the tumor could be an issue, could be a clue to go for the angio after the MRI. So I would be happy to have their comment about that. A selection of the patient for selection of the meningiomas for embolization. Well, I do not know. If we take the one from McDermott from San Francisco, they do have a very large range of indication for selection for embolization. They exclude the patient from which display tuberculum cellae or factory groove meningiomas because they consider that it's too risky for the carotid artery, the ophthalmic artery, because of the anastomosis with extracranial system. However, apart from this case, once the tumor size is more than 2 centimeters, they go for angio and they go for embolization. I find it very aggressive. I find it probably a little bit overestimated, because a 2 centimeter CPA meningioma in my hands is not probably eligible for pre-op embolization. So it is something that we could discuss. This is a criterion for the selection of the patient with the consider eligible for embolization before the surgery. You see, they showed on the right part of the slide on this graph the respective supplies on blue and the respective vessel which were embolized, and of course they are very aggressive with the external extracranial system, particularly middle meningeal artery, internal maxillary, ascending pharyngeal artery. They do that. Conversely, they are very reluctant to embolize the meningohypophyseal trunk and or the ethmoidal and ophthalmic artery, which makes sense. Okay, the results. This is a slide which I find it very interesting because it provides a classification of the effectiveness of the embolization, and they do that with a simple MRI just after the embolization. They measure the signal into the tumor and T1 in injected T1 slides, and they classify that in 4 grades. Grade 4 means that you have embolized more than 50% of the tumor. Grade 1 means you have done 0, and it's pretty much nice, and it's interesting because it correlates during the surgery with the blood loss. Clearly, they demonstrate that for grade 4, the blood loss is very, very, very low. Conversely, in grade 1, of course, the blood loss is the one that they could expect if you didn't embolize the patient. Results for the skull-based meningioma embolization is the level of evidence is very low because you don't have any case control study, of course. You don't have, of course, randomized studies. So you have only cohort studies showing what they do and what we do. And you can see here that the use of adjuvant is very wide. Particles, powder, onyx, glue, all of the devices have been used. The vessels that have been embolized, they show that, and it's extremely, the span of these vessels is very wide. The location of the meningioma that have been embolized is very wide too, and the outcome, they show the ability to embolize the full extent of the tumor and the percentage of complications coming from 6 to 11% of complications. Okay, it has been shown by our colleague there are anastomosis between the external and the intracranial system. You have 3 targets. And we have to be aware that we don't want to have some accident, ischemia into the brain. You have to pay attention to this anastomosis that can be opened during the surgery, or opened during the tumor, during the embolization. Sorry, so you have to know that before doing the embolization. But thanks to the microcatheterism and the fantastic analysis, we can see now that this kind of anastomosis are open or not. There is an interesting syndrome that I found in the literature, which is called the post-embolization neurological syndrome, PENS. In this series of Japanese people, they published that they embolized 39 patients, and in 5 of them, they found this kind of syndrome. The syndrome is the fact that the patient complains of headaches, vomiting, the body temperature is increasing, and it's between day 1 and day 2. And usually you have the exacerbation of the symptoms of the patient. And they say that they do have these symptoms when the embolization is complete, particularly in grade 4. And they explain that because of the edema due to the embolization after the embolization. This is always something which is transient. It's probably helpful to administrate steroid in the patients and probably to operate these patients within the 48 hours, and we usually do that in the 24, as said Sebastian. So the more you embolize the tumor, the more you can find this kind of PENS, which is a syndrome which is serious, and you have to pay attention to that. I found another way to devascularize the tumor before the surgery. I don't know if Sebastian do that, or if you do that, but particularly in wide anterior skull-based meningioma, if you want to avoid any accident with the ophthalmic artery, you can approach the ethmoidal artery surgically with open surgery or with endoscopy and coagulate both ethmoidal, anterior and posterior ethmoidal artery. And I found that very nice and very convincing. Of course, it's not a recent publication, but this kind of mini approach before the surgery can optimize the surgery, particularly in giant skull-based, anterior skull-based meningioma or hemangioparasitoma. By the way, hemangioparasitoma, the skull-based, are very aggressive and very vascular, very bloody. So the last part of my talk is very short because this is only one slide. This is one. Well, in the hands of skull-based neurosurgeons, of course, you do have to embolize the patient if you are convinced that it works. And I showed you that in JNA and in paraganglioma, in my hands, it is systematic. I'm more reluctant to do that in meningiomas, but well, I do admit that I was convinced by the presentations of our colleagues from Lavoisier. But the regular microsurgical techniques, once you operate the patient with a skull-based approach, meaning that you control the bone, meaning that you control the dura at the level of the skull base, usually you can devascularize. Another issue is once you are inside the cavernous sinus, which is more challenging because the surgical control of the intracavernous carotid artery, which is the case here, this patient had an hemangioparasitoma which was malignant, and we offered him, I wouldn't say an exenteration, but optimal, close to be radical resection while preserving the internal carotid artery inside the cavernous sinus. Of course, the patient was already ophthalmoplegic with hyperesthesia on the fascia and the trigeminal nerve, and no clue with the cranial nerves. But since the patency, the balloon occlusion test wasn't very much tolerated in this case, and since we were reluctant to offer a conservative bypass before the surgery, we offered this conservative transcavernous approach, dealing with the feeders coming from the internal carotid artery and seeing the feeders directly from the carotid artery. So, I mean, pre-op embolization is key. To master the microsurgical techniques which has offered by the surgical approach using the transpetrosal and the also skull base approach is something which is really very important in the end of the neurosurgeons. This is probably the end of my talk, and I thank you, sir.
Thank you so much, Pierre, for this very interesting talk, showing the different tumor and indications that can be applied when dealing with very vascularized processes. And you started a discussion about the indication of preoperative embolization. In your experience and your hands, what are the good indication? What is a bad indication? You show us a diagram with maybe a too extensive way to deal with preoperative embolization, but in your experience, what is the good patient? What is not the good patient?
Sorry, I stopped I told in the beginning, I stopped to embolize the meningiomas. You know, I stopped to embolize because, but once again, I can accept that all the teams do differently. But for the meningiomas, I'm reluctant to offer pre-op embolization. We do operate a lot of petroclival. We operated probably 120 petroclival meningiomas, and if I look at the rate of blood transfusion of the patient, it's very low. Why? Because in the hand of skull-based neurosurgeons, we control the feeders very early. I do accept what said Sébastien. Depending on the vascularization, you are influenced in the way you will select the approach. But this is not my way. I'm much more interested on the epicenter of the tumor, and I'm much more interested in the distortion of the cranial nerves to select my skull-base approach. And thanks to the techniques we have in our hands, coagulations, flow seal, all this stuff, I'm usually not very much concerned about the intra-op vascularization, even in very large meningiomas. Meningioma is something. JNA paraganglioma is completely different. Hemangioparasitoma is different. But in skull-based meningioma, I do not do that anymore. Well, perhaps I'm wrong. I don't know, but I do not see the benefit unless it improves the softness of the tumor. I do believe that to soften, to provide necrosis, it's advantageous because it improves, it speeds up the surgery. But does it limit the blood transfusion of your patient, the blood loss? Well, what's the evidence? I'm not sure, but let's have the discussion about that.
Yes, maybe it will be the controversy with Sébastien. Sébastien, are you still with us? Maybe he has to leave to other activities at the AirCAD. And Marc-Antoine?
Yes, thank you for your excellent presentation. I totally agree that there are no evidence about the benefit of embolization. It will be difficult for me to tell you that there is benefits. It's the neurosurgeon who tell that at the end. I think the message could be that you just have to occlude feeders when there are no risk of complication. I know that there are never no risk in medicine, but in some occlusion like APA, ascending pharyngeal artery, or middle meningeal artery, I think it's very, very uncommon that there are complications if you know well how to embolize and you respect rules. So yes, I can answer for the neurosurgeon, but I suppose that if yes, it could be interesting to limit the time of the procedure and to help for the neurosurgeon.
Dr. Laberry, can I ask you about the time? The time it spanned to embolize a big meningioma, and what the cost of the procedure? Can you tell us that?
Yes, yes, it's an excellent question. It takes time. It could take about 2 hours because endovascular procedure are never a short procedure because it's like that. But it's not the time which makes more complication. It could be it's not associated to the time of the procedure, and for the cost. It depends if you use microparticles or coils. It's never a lot to include MMA or APA. Probably, yes, it costs 1,000, 2,000 euro if you use lots of coils. But unfortunately, our specialty are very expensive now, but yes, it's true. It costs us a bit.
I would say that one of the big points is the complication rate, and as soon as the complication rate can be very low in some experience, it ends. The benefit for a petroclavide meningioma, I'm not favoring a lot of indications for preoperative embolization, but for big petroclavide meningiomas, it can, in my opinion, be helpful as soon as the complication rate is very low, and it seems to be in our team.
It's not because we are the best, but it's just to limit the indication. We only perform 20. We only add 20% of complete devascularization. That means that 80% of the patient have just partial embolization. So if you just accept that if it is difficult or dangerous, you don't do it, and it's okay. You have necessarily a low rate of complication.
No, but I'm convinced that the evolution of the devices and the education of the radiologists make it definitely safer than in the past. And as long as you have the control of what you are doing, and I'm sure you do, as long as you do that safely, as you said, and as long as you can control in real time, I'm happy to see this evolution. And probably I will change. Probably I will move back to what you are doing. But we did in the past, with the device and experience, which was not the one you show today. And I'm convinced that it's feasible, that it looks safer. I'm convinced that it can help to soften the tumor. But about the blood loss is not an argument, and recurrence limitation. You know, you told about recurrence. Well, it's you're optimistic. It looks a little bit speculative, unless you achieve Simpson 1 resection in these tumors. But you achieve Simpson 1 resection because you remove the bone and you remove the dura. If you remove the pitous bone and the dura of the tentorium, you can achieve Simpson 1. But I'm not sure this is because embolization that you mean you will achieve Simpson 1.
Yeah. I just mean that the blood loss is not sufficient goal to explain the patient and to justify such treatment, because yes, you can just give blood and it's okay. But I think when you have a very long procedure, and I'm not neurosurgeon, but I suppose when you have a very long procedure with a lot of bleeding and you takes lots of time to control the bleeding, and you have to make a resection of a very big skull-based meningioma. I suppose it is not the best way to achieve a complete resection, because you spend lots of time and perhaps stress, I don't know, to take time to control the bleeding. It's why I speculated that it could make a difference for the residual. There is one meta-analysis, but I totally agree that it's just speculation, but one meta-analysis which suggests this kind of effect, but it has been to be proven, of course.
One of the advantages you told, Pierre, also is the softening of the tumor, and maybe due to the softening, you can speed up the intratumoral debulking and maybe reach more easily your feeders as well. Because when you have a big mass effect with a big deep located tumor such as petroclival meningioma, your feeders will maybe be more reachable if the tumor can be already debulked at the beginning of the procedure. And you can do that because it is devascularized by endovascular means. Any comment?
What we can do together with the group of the skull-based guys is to launch a match study. You know, we have the same way to operate the patients. We do the same techniques, almost. Some of us, we are reluctant to embolize. The other one, they are in favor to embolize. We can match our results in terms of blood loss, operative time, all the things. It's achievable to do that. Why not? We can share data about that, and yes, because
with pleasure. I think it has been already down in literature, and it will be limited by you know, the retrospective and match control. But yeah, it could be interesting, of course. And ideally, we should randomize this kind of treatment. And I think because there are quite a lot of patients who are treated, it could be achieved if we do a national study like that. Could be achieved quite quickly to randomize embolization or not before surgery. I think it's the best way to demonstrate the benefits.
Okay.
It will be one of the future work of the skull-based section. Thank you for the idea, Pierre.
Good luck.
And so I think we will gently finish. I would like to express my thankfulness to you for this very nice talk and very interesting discussion. The next and last skull-based webinar that we will organize this year, I will say, with the term of the current panelist of the skull-based section will be in September, around mid-September, and I will invite you to join us at that time. We will have worked together 4 years, and it will be the last webinar organized in this second term of the skull-based section team. So I invite you to join us at that time in September. Anna and DNS will confirm you the exact date.
Michael, you did an excellent job during these 4 years, and you gave a direction for the group, and you did a lot, and the webinars were excellent, all of them. And I thank you for your leadership and what you did for the group.
Thank you so much, Pierre. The last webinar will be dedicated to the best of, and I will suggest that all the panelists, we are more than 15, will give a short talk of 5 minutes by sample of one surgery you would like to emphasize. I think it will be a nice happy end. So I invite you to be there in September and have a nice summer in the meantime. See you next time. Thank you, Pierre-Hugues, Sébastien.
Thank you.
See you next time. Thank you, Anna,
so much.
for the organization and Prodromos. Bye-bye.
Bye-bye.